Perfect. So I'm Forensic Patafio. I'm one of the medical oncologists at Mackenzie Health, and today I was asked to talk about immunotherapy, which is not the standard of care yet, but it's quite an exciting time in immunotherapy. At Sunnybrook, we had 3 immunotherapy trials. 2 are still currently running still, so I'll talk about that. Here are my disclosures. So immuno-oncology, it's quite nerdy, and I'll talk more about it. How immunotherapy pretty much works with tumors is that tumors can evade the immune system by various mechanisms. It sort of creates a micro immunosuppressive environment around it. And I always tell my patients it's sort of like a Jedi mind trick. The immune system comes by and says, there's a cancer there, and then the tumor says, I'm normal, move along. And it's actually much more complicated than that, involving many handshakes with the immune system. Some of these are PD-L1 and CTLA-4, and we have 2 drugs available for that currently. So I'll spend most of my time talking about that. So there's a schematic here on the left side. We have a tumor cell which is presenting an antigen and labeling it for cytotoxic death by the T cell. But what the tumor cells sometimes do is overexpress PD-L1, which then shuts down the T cell and it moves on its way. But by using immunotherapy, we can block either the ligand at the tumor itself or the receptor at the T cell, and then label that cell for cytotoxic death. So currently in Ontario, we have many immunotherapies for different tumor sites. The big 2 that we typically talk about is pembrolizumab and nivolumab. Those are PD-1 inhibitors that are targeting the receptor at the T cell, and you can see the sites which we have it currently available for. We have PD-L1 inhibitors as well, avelumab, atezolizumab, and durvalumab, which are available for those sites there. So what about PD-L1 expression in NETs? Well, we know PD-L1 expression is associated with better response to immunotherapy. In lung NETs, about 10% of large cell neuroendocrine carcinomas do express PD-L1, 5% in small cell, but not typically in atypical and typical lung. In GEP NETs, it's about 1 to 8%. So overall, a small population that expresses PD-L1, but a significant portion of NET patients. So at Sunnybrook, we have 3 trials running, actually 2 running now, 1 was closed. The first 2, NET-001, which was avelumab, and this is for patients, this is a phase 2 trial for patients who've progressed on previous therapy with poorly differentiated grade 3 neuroendocrine carcinomas. NET-001 is a similar trial, phase 2 single-arm trial, but for well-differentiated tumors, grade 2 to 3, grade 1s are excluded. And then PDR-001, which was we recruited for but closed, and I'll talk about that right now. So PDR-001 is now known as spartalizumab, which is a PD-1 inhibitor. In this trial, we gave all patients the immunotherapy agent, and the patients that were sort of 2 groups. One was a well-differentiated grade 1 and grade 2 NETs. They had to be non-functioning, and they had to progress on previous lines of therapy. The other group was the poorly differentiated neuroendocrine carcinoma, which have progressed on therapy. Total accrual for across the trial was 116 patients. The intervention was, of course, PDR-001, which is given IV every 4 weeks, and the primary outcome is overall response rate. The preliminary data was presented this fall at ESMO, and you can see here in the table, for the well-differentiated group, the T means thoracic, P pancreatic, and GGI. The main response rate was seen in thoracic atypical, about 20% of patients responded to single-agent immunotherapy, but the overall response rate for the well-differentiated group is around 7.4%, but most patients got stable disease. For the neuroendocrine carcinoma group, unfortunately, the response rate was quite low, about 4.8%. Most people did, unfortunately, progress on trial. But what we did find in this trial is that immunotherapy is very well tolerated, and that's what's great about immunotherapy. Very minimal side effects, but manageable side effects. We also did analysis of PD-L1 in the trial, and unfortunately, a lot of PD-L1 low expressors in the well-differentiated group. In the high-grade groups and the poorly differentiated, we had higher rates of PD-L1, but unfortunately that didn't matter. So it's not a really good predictive indicator of response to single-agent immunotherapy. There were some other investigative things we looked at as well as TIM3. The second immunotherapy trial that presented this year was Keynote 158, and this is a basket trial of all uncommon tumors together who have progressed on their standard therapy, and they all get randomized to immunotherapy. And so there was a subset of neuroendocrine tumor patients in this trial of well and moderately differentiated of lung and GEP who have progressed on therapy. And they all received pembrolizumab, which is a PD-1 inhibitor, IV every 3 weeks for up to 2 years. And the primary outcome was overall response rate. And this was presented a few months ago at GASCO in San Fran. And totally there was 107 patients in this trial, and unfortunately the response rate overall was quite low, about 3.7% of patients. There were only 4 responders out of all 107 patients. Interestingly, all of those 4 responders, all of them were PD-1 negative. So again, not a really good biomarker of response rate. Unlike the previous trial, most of these patients were pancreatic who responded, so we're sort of getting a mixed bag here. And median PFS was 4.1 months. So why isn't single-agent immunotherapy not really working in our disease site? Well, what we're knowing now is that it's not PD-L1, it's mainly more of tumor mutational burden. So you can see here on the graph here, on the bottom is tumor sites, on the Y is frequency of tumor mutational burden. And we know from the lung data, it's really 10 mutations per 10 megabase pair is where you really see single-agent immunotherapy work. You can see here on the right, melanoma and adenocarcinoma, really great response rates to single-agent immunotherapy. Carcinoid is there in the green, third from the left, and it's sort of low. So we need to look beyond that. We need to start looking at combining immunotherapy. And I don't want to give up on immunotherapy yet, and there's actually a great publication that came out this year looking at extensive stage small cell lung cancer, which is the sister of our high-grade neuroendocrine tumor. We treat them identically because they behave the same. And the trial is IMpower 133. So let's talk about it. So that's a trial looking at patients with extensive stage small cell lung cancer who've never received previous therapy. They get randomized to standard of care, which is platinum doublet, carboplatin etoposide, or platinum etoposide plus an immunotherapy. They get 4 cycles of treatment, then they go on a maintenance immunotherapy until progression. And the primary outcome is overall survival. And these are the results, and they were presented actually in Toronto last fall as well, and it was truly amazing that there was a 30% reduction in death in the combination immunotherapy arm. And I think this has become the standard of care for high-grade, for extensive stage small cell. And will it become for high-grade? We'll have to wait and see. But it's truly amazing to actually see a survival benefit in this disease site. And it's been 27 years of negative trial after negative trial for extensive stage disease with no improvement, and we finally have it. So I think with immunotherapy, we really just need to combine it. There's also some data with breast, which I won't go into as well, but really showing a huge improvement when you combine it with immunotherapy, these very aggressive cancers. By going on treatment with chemo and then doing maintenance, you get really good outcomes. So how do we improve single-agent immunotherapy in our disease sites with neuroendocrine tumors? Well, I think we need to do combination. So there's already some trials in the States and Europe who have already jumped on this bandwagon of combining PD-1 inhibitor with a CTLA-4 to get better response. So there's Ipi-Nivo and Durva-Tremi. There's 2 trials there. But also immunotherapy plus other agents, right? And so in the States, they're running pembrolizumab plus liver-directed therapy, maybe as a way to induce immunogenicity within the tumor itself. Pembro plus lanreotide in the first-line setting. Pembrolizumab and Cobi, which is a MEK inhibitor. And what I'm most excited about is immunotherapy plus temozolomide for pancreatic nets, because we know now pancreas nets really respond well to temozolomide. Can we make that response rate even better with immunotherapy? So the bottom line for immunotherapy in nets, it's not very active for single-agent disease. Most patients are getting stable disease, which is fine. There are some responders, but we need better predictive biomarkers of who those patients are. The classic biomarkers of disease site, KI, differentiation are not really strongly predictive. Maybe tumor mutational burden or negative biomarkers are available, but pretty much now I think we have to start moving towards combining immunotherapy with previous standard agents or new agents. Thank you.
What a whirlwind tour of all the available agents for treatment. That's been phenomenal. Thank you. We have about 5 minutes, just a little over 5 minutes for some questions. So we're going to start with the panel that's at the front, and I would like to ask any of you who have questions for these speakers at this point, please. Everyone's overwhelmed, eh? Yes, you've got a question.
I have a question around surgery. So that was an excellent review about when we would use surgery. But what patients would you not consider surgery for?
Shall I start? Well, what patients would I not consider surgery for? Well, I think like I say, it really gets down to, I guess there are a couple of factors. One is either, sorry, I tend to mumble, as my kids will tell you. So I think there are a couple of issues. Sometimes you cannot, for the reasons that Carmine elucidated. It's too extensive. It's invading structures that are required for life, and it becomes technically too risky to remove. And I think that's certainly one. The second is when there may not be any real surgical option. I mean, if you look at a liver, for instance, as an example, where you need to have good inflow in artery vein, bile duct out, and good outflow out in decent volume, you may not be able to design an operation that actually manages that within the scale of disease that you're looking at. And then the third and perhaps the most important one is again the biology. I mean, if you have a disease that's rapidly expanding, cascading, accelerating, there's no treatment on earth really that's going to help that. Now, unfortunately, that's a small minority of patients, but I think really what you're hearing in this panel in particular, beautifully, is that this is always a multidisciplinary decision, discussion, and really what people are trying to do is bring to bear as many minds and as many treatment modalities as possible for every specific patient. And sometimes that's surgery, and sometimes it's not. Now, one of the cool things about the immunotherapy trials you're seeing is I think ultimately what we might do is be able to take what's previously unresectable and shrink it down to the point that surgery does become an option. Did you
Great. Yes, a question here.
Dr. Racing, I don't know if I misunderstood you. You used the term regression might be a problem. Was that somehow connected to the use of sandostatin, or did I misinterpret?
No, regression, no, I wouldn't have said regression might be a problem. It's that regression almost never happens with somatostatin analog. The goal is really stabilization. Yeah. Sorry if I misspoke.
Other questions? Yes.
On sandostatin, you said, it causes gallstones and gallbladder problems. And I've been on it for a little over 6 years now. And I have just the last gallium PET showed the gallstones. I've had 3 reoccurrences, like in 2 years. And then this year I had little spots on my scalp and maybe some things on my skin and stuff. Do you think the sandostatin is still beneficial to take? Being I'm having reoccurrences and then seeing gallstones?
Yeah, well, it's difficult one to answer without knowing a little bit more background, but I think broadly speaking, many times, and again, depending on the situation, so please, with all the caveats, we might continue sandostatin, assuming we're keeping one foot on the brake of growth. Yes. Can we really say we know that for sure? Likely not, to be honest. But it's a strategy that's discussed sort of individually, but also depending on the pace of progression, where the recurrences are, how frequent they are, whether or not they can be approached with a different treatment. And the story with the gallstones, maybe I'll turn it over to my surgical colleague in terms of answering that question. I mean, it is definitely a long-term risk. And again, it has to be weighed against potential benefit, and there's a lot of uncertainty there. I don't know if you...
So every year we have a few patients who are on long-term somatostatin and develop gallstones, and occasionally have had to stop treatment, but we usually restrict that to the symptomatic gallstones. So if you have biliary colic, for instance, then we'll stop the sandostatin or reduce the dose, and if it's still a biliary colic, then operate. Yeah, I would wait.
Other questions from the audience now? If not, we're going to take a short break. At 3 p.m. we'll reconvene. We're going to have one more formal presentation, and then we're going to break up into the roundtable groups, and there'll be... Oh, one more question. Sorry, I missed it. Okay.
And there's a presentation after the break.
Yeah, I said there's going to be one more formal presentation and then the groups, the small groups.
Would it be beneficial to have the gallium scan if you don't light up with your other scans?
You mean the actual scan?
Yeah.
I would go for the gallium-68. It's more sensitive scan. Definitely, yes.
Okay, thank you.
Great. Thank you very much. Break time back at 3 p.m., please.